I want to thank all of you for being here and really appreciate the work that you do. And I want not only to impart what I can share with you today, but part, I think, of what my responsibility to you today is to facilitate a conversation amongst you, because I want to really respect your expertise. I had no idea that some of you had been doing this for 15 years. So as much as I think I know about this population of helping pregnant women with quitting smoking, I respect that you likely know a lot more about this than I do. And I want to facilitate conversation amongst you. So I can feel the kind of buzz in the air and the excitement about being here. And I'm going to capitalize on that this morning and give you some assignments and some things to talk about in small groups so that we can share our expertise with one another. So I've had my job at the Nicotine Dependence Center at Mayo for about 11 years this year. So I have not been doing what you've been doing for 15 years. Only 11 years. And part of my job is being involved in the tobacco treatment specialist certification training, which is going on right now this week. And so your name was again? Sarah was saying she was supposed to be here, be there at Mayo this week and wasn't able to be there. But they had to come up with a pinch hitter to cover for me today so that I could be here with you. How many of you are trained as tobacco treatment specialists? Anybody? Wow, excellent. Just one, or was there another? Over here, two? Oh, that's right. I said hi to you this morning. So good. That's going the extra mile for sure. And I'd love to invite any of you who would be interested in doing that to do it. It's a 5-day program that we do at Mayo. And you fly on over and you spend the week. You take a certification exam at the end of the week, and then you could add letters after your name, because a lot of us like to collect letters after our names. And I'm also the program director for the Mayo Clinic Wellness Coaching certification. And I want to share that that's part of my expertise that I'm going to share with you today. And so I know that there are a lot of people who help people with alcohol use here today, not just tobacco. And that's my bias. I'm going to be talking a lot about tobacco use, and I want to make sure that I'm being inclusive of you guys who work more with alcohol and not tobacco, assuring you that the skills are the same. A lot of the things that I'm going to be talking about, even though I use the word smoking and tobacco a lot, the skills that I'm going to be talking about are really from the Wellness Coach training program, the things that I'm going to be sharing with you, and that I'm going to be able to include you all in that, okay? Every once in a while I'm going to have to come look at my notes and make sure I'm not forgetting anything, because some of these things are new slides for me here. Okay. Well, let's look at my learning objectives. What I want to talk about today is the theme of the whole day is identifying these social risk factors, some of them that might be modifiable, some of them that might be not so modifiable by things that we can impact, and talking about those. And then talk about some key relationship building skills that we can use, wellness coaching strategies specifically, that can really make a difference in the interventions, maybe the power of the interventions that you have with women. And then also explore some strategies that we teach in the wellness coaching training program about getting people back on track when they want to talk about everything except what you want them to talk about. And if that's never been a problem for you, I don't believe it. Okay? I want to talk about one of my favorite patients, and we're going to keep on coming back to talking about Jackie. And Jackie is kind of an amalgamation of several of different patients, so you know you won't see anybody that you know in Jackie, but she is 24 years old, and she's 4 months pregnant with her second baby. And she normally smokes pretty heavily. She dips into her second pack of cigarettes every day. She smokes 20 to 25 cigarettes a day, but she's cut down, which is worthy of admiration. She has cut down. She has a 2-year-old daughter named Alicia, and when she was pregnant with Alicia, she cut way down. She was smoking less then. She got down to 1 to 2 cigarettes a day, but immediately after delivering this baby, was back to her normal use of about 20 to 25 cigarettes a day. And she avoids smoking until about 45 minutes after she gets up, because she takes care of Alicia first, which is, I think, a real strength. And I love Jackie. She's a neat person. She's funny, and she's a hard worker, and she's smart, and I enjoy meeting with her. I really do. And she is loyal, and she's the kind of person who would do anything for her friends and for her family. But there are some things in her life that set her up, right? To set her up to be using tobacco. And I think you guys probably know Jackie. You probably work with Jackie. I'm wondering, what kinds of factors do you see that set people up? You know, that kind of predispose people. Yeah. Stress. And why does Jackie have more stress than your average person?
Maybe working a lot and having a child.
Working a lot, having a child. Okay, sure, yeah.
Cultural background.
Cultural background. So you're thinking specifically related to Jackie.
I think
How so?
Native American because I work for a tribal health
Okay.
facility. So that automatically pops into my mind, but I know a lot of, African American, just a lot of different ethnic backgrounds.
Certain ethnic backgrounds, racial groups tend to smoke more than others, and Native Americans are one of them, for sure. And that definitely could be Jackie's background. It was a neat study done a couple of years ago, ironically, and happily, by the Wisconsin Department of Health. It was done by via a national grant that actually looked at tobacco use disparities and found about 9 different areas that really showed pockets of people that were set up to use tobacco more than your average person. And Jackie really fits into quite a few of these different areas. So they really overlap. And one area is high prevalence. So like you said, certain populations just smoke more. Native Americans are one population of people that didn't finish high school, is another group that really tends to smoke a lot more. And tobacco use in these groups can be just so normal that it can block an awareness in a person's mind that it's even important to be thinking about quitting, because everyone you know smokes. And I recognize that in myself as a bias that I have to be careful about, because in my life, if I really stop to reflect about it, I don't think I have a single close friend or family member that smokes. Like nobody. Like I can't think of anyone in my social network who's a smoker. And so my response to Jackie and my understanding of her network and in her high prevalence culture, I have to work at it. I have to really think about putting myself in her shoes to understand. So Jackie's mom smokes, and her sister smokes, and Jackie's husband John also smokes. And it was normal in Jackie's home growing up. Like just the smell of pipe tobacco reminds Jackie of her grandpa, and it reminds her of family gatherings. And it's a really positive, she remembers that people used to actually give and get cartons of cigarettes for Christmas at Jackie's house. I mean, I don't think, maybe that's as prevalent as it used to be, but do you remember the old Chesterfield ads in the magazines? actually had Chesterfield cigarettes wrapped up like Christmas presents. Like that was an actual viable gift that you would give someone, which is hard for me to understand, but in Jackie's family was really something normal. And every once in a while for Jackie, someone might try and quit, but no one ever really was ever successful. They were sort of half-hearted attempts, and they would kind of laugh at it, like, oh, okay, yeah, Uncle Joe's going to try to quit again, whatever. And we know it's not going to work, and it's not going to go anywhere. And so not only is there a blocking of awareness that it's important, there's also a blocking of awareness that it's even possible, because she doesn't have a lot of people in her social network who quit successfully and are ex-smokers. Everyone's just still smoking for her. And so high prevalence is one of the issues that we're working with. And then the other population that maybe Jackie belongs to is a group that has been highly impacted by this high morbidity and high mortality. So if you're a member of a group that was targeted to use menthol cigarettes, for instance. So African Americans, right, smoke Cool cigarettes and Newport cigarettes. That's the stereotype. And because that's really what's marketed to that group. And if you smoke menthol cigarettes, it anesthetizes the airways in your lungs. You can inhale more deeply and hold your breath longer. It's associated with more small cell lung cancers and more diseases. And then this group is also already biologically more vulnerable to tobacco-related diseases, like heart disease and lung disease. So, and certain groups also are less likely to access early health care, like more likely to wait until it's too late to get help for certain kinds of diseases. So here, Jackie's dad died when he was 52 years old only of lung cancer. He had symptoms, didn't want to go to the doctor, one of those guys who doesn't go to the doctor. And when he got help, it was too late, and they lost him really early. And both Jackie and John have quite a few relatives that have gotten ill early in their life with tobacco-related diseases, gotten COPD or emphysema or heart failure, that really diminished their ability to live a full life. So what we see with people who use tobacco, they live short and they die long. So everyone wants to live long, right, and die short. What we want to do is we want to have this long, full life and enjoy things. And then when you're like 86, you want to have your favorite meal and you want to see a good movie and say, goodbye to all your friends and family and die in your sleep. Right? And you can say, I lived a good life. But we see people who use tobacco do this thing where they live shorter, but then they get ill with some sort of lingering tobacco-related disease like COPD that's painful to watch people to live with, that diminishes people's ability to have fun and do the things that they want to do and go to the mall and babysit their grandkids. And so, like Jackie's grandma got heart failure in her early 60s that just made her slow down and made her feel sick and made her just diminish her capacity to have a fun and happy life. And we see this in a lot of Jackie's family members. But Jackie doesn't really see this as anything that's tobacco related. The lore in her family is that we have bad genes. This kind of thing just runs in our family. And the early deaths, the kind of illness that she's experiencing in her family, those deaths or illness aren't really regarded as something that could be avoidable or it should have been avoidable. It's tragic and sad, but geez, that's just the way it was because we have bad genes. And so also dealing with that kind of illness in a family really diminishes the financial capacity. When her dad had lung cancer, Jackie took on a lot of responsibility for taking care of her dad and ended up taking off so much work that she lost her job. She had to keep on taking off work to take her dad to these doctor appointments, and she didn't have any PTO where she worked. She was an hourly worker, ended up losing her job. And then there was a lot of resentment between her family members, right? Like, who's going to take dad to his appointment today? I can't go, you need to go. And this increased stress with the financial problems. So this high morbidity, mortality can really cause families to suffer.
We know that other groups have other specific vulnerabilities too. We know that obviously pregnant smokers are really, really impacted by this because of what the impact it has on kids. Like her daughter Alicia, the 2-year-old, has already had 3 ear infections this year, all related to secondhand smoke, all in causing Jackie to lose work. And you can't send your kid to daycare when she's got an ear infection. And Alicia also was really a colicky baby when she was little and was crying all the time, which increased a lot of the stress in her family's household. We know that also Jackie takes medication for depression, and people with mental illness require higher doses of medication, more intense treatment in order to be able to successfully quit smoking. And so there may even be a biological vulnerability with certain kinds of mental illness, predisposing people to be more sensitive to tobacco addiction. So that's a difficult population as well that's like unfairly impacted by tobacco use. And then people who are already ill with tobacco-related illnesses. I mean, if you can imagine Jackie's grandma who continued to smoke when she already had heart failure. And it was just that much harder for her to manage being a smoker when she was already sick. So those are a couple of other groups that are challenged.
Tobacco industry targeting, in Jackie's case, she's a young woman and she's 24 years old. Young people are targeted specifically by the tobacco industry in certain venues that are popular with young people. Plus, she just barely graduated from high school. She doesn't have any other education, and that's another way that she's really singled out and targeted. Jackie and John struggle financially, and they're not buying cartons of cigarettes. I don't know, what is the tax on a pack of cigarettes in Wisconsin? Anybody? I should have looked this up. It's like $2.60 or 70 cents a pack in Minnesota, and that helps. When the product is unaffordable, it does help people limit the amount that they smoke. But depending on what the taxes are here, I'm not sure. $2.52. Someone just Googled it. Thank you. That's right. $2.50. Very similar to what we did have in Minnesota. It's the highest in New York, and like the lowest in Missouri. 17 cents a pack. I just did C.T.T.S there last week. I was like, 17 cents a pack? Really? That's not helping anybody. But they really, they're the kind of people who save all the like box tops and things that you send in. They join all the clubs where you get the coupons in the mail. Have you ever done that? Have you ever joined one of those clubs just for fun to see what you get? It's amazing the amount of money the tobacco industry spends on this targeting. You get like, the packaging is gratuitous. Like a package inside of a package inside of a package to get this 50-cent coupon in the middle. But it's very beautiful and it's all very seductive. These are coupons here for $1.50 off a single pack of Camels, or $3 off of 2 packs, and they really collect and look for those coupons and use them at the convenience stores because they're buying these a pack a day, actually stopping at the convenience store, buying these quite a bit, a pack a day, but they can't afford to do it any other way. Then there's just permissive cultures, cultures that are just tolerant of smoking or even subtly intolerant of not smoking. What's your experience with that, with patients? Do patients get like subtly influenced not to quit by people? And you need what do we know about quitting smoking? You need a lot of social support to pull this off. You need a lot of friends to call and people to say, I'm so proud of you. You're doing a good job. How are you doing not smoking today? But if people around you are indifferent to whether or not you quit and aren't, giving you, or even thinking maybe in their mind, if Jackie quits, she's probably going to start pressuring me to quit next. And I'm not interested in doing that. The subtle criticism of, if Jackie may feel like she's subtly criticizing the people that she loves by quitting, by implying that what they're doing isn't right. And so she's got some social pressures that keep her smoking, and little support. You see it, you smell it. Absolutely. I mean, we know now that secondhand smoke triggers the nicotinic receptors in the brain to cause physiological urges to smoke. You can see them on a PET scan. Like if you put a non-smoker or an ex-smoker in a car, in a simulated car setting, have someone smoking next to them, have them hooked up to a PET scan, you actually see brain activity in those receptors that cause urges and cravings to smoke. And being around other people who smoke really increases the challenge here. And so there are certain cultures, right, where you're just going to see more of that saturated smoking behavior. You'll see that in the LGBT population, a lot higher. The highest rate of smoking that I am aware of is within the LGBT culture. Women who have sex with women can smoke up to 200% more than the rest of the population. 200% more. That's like out of control. And so we know that people who have been in the prison system, correctional offenders, juvenile offenders, and people within the drug use culture smoke more too. So at Jackie's house, her husband John smokes quite a lot of marijuana, and a lot of John's friends smoke quite a lot of marijuana. Jackie doesn't really so much herself, but that's around her. And if they were going to quit anything, at Jackie's house, they'd be thinking about, we need to be quitting these other drugs. But they wouldn't be talking so much about quitting smoking, right? Okay. It's another population. Permissive work environments. So you've got pretty clean indoor air legislation here, right, in Wisconsin? You got pretty good protection for people where they work. Still, that there's some tricky spots because Jackie works in food service. She's a server at like Perkins, like a chain restaurant, and at least 30% of her coworkers smoke, and they all go out and smoke together on breaks. So even if you can't smoke right there in Perkins, they're all out the back door by the dumpsters every chance they can smoking. And her husband John's a construction worker, and he's out on site, and he can smoke as much as he wants without restriction. Right now, it's during the kind of the tail end of the off season, so he's working at one of those big box home improvement stores, but he's smoking at every break opportunity too. And he can't get any time off right now either because he's one of those hourly workers. He doesn't have any benefits. This is one of Jackie's co-workers, and I don't know if you can see what's happening here. Poor, much maligned Melissa Williamson. She's 35 years old, and she's a Bullitt Avenue resident who worries about the effect of on her unborn child from the sound of jackhammers. She's got a cigarette right there. This poor woman has been used in so many slide presentations. I don't know if she even knows that this is the poor thing, but yeah, this is Melissa, and she works with Jackie, and they have kind of this unregulated environment, and we know that there are two things that impact the rate of smoking in a population. Two things that have been shown. Anybody know what they are? What brings down the rate of smoking in a population? Clean indoor air legislation is one, because if people can't smoke at work, they really start cutting down. It becomes really inconvenient, and it really causes a lot of people to make more quit attempts because they just get sick of trying to have to go across the street to smoke at work. What's the other thing?
Health insurance?
Oh, health insurance helps. I'm sure it helps, but it's not one. It'll help people quit. There's one thing that's more measurable even than that. Increased taxes. So whenever it comes around where you have the opportunity to vote, vote for increased taxes, because the people who are impacted most by smoking are people with low socioeconomic status. They suffer the most. They spend the largest component of their income on cigarettes. They suffer from this high morbidity and mortality, and they're actually the ones who end up benefiting the most from quitting. So sometimes we think of increased taxes, right, as a tax on the poor. It ends up being really in everyone's best interest to help people quit. And they're the people who get to reap the benefits of no longer smoking. So those two things are really worth voting for.
Okay. Barriers to access, this is what increased health insurance coverage is great for. We want to remove barriers to access, right? So we're hoping that health insurance doesn't charge co-pays and gives away free medication, because those things are associated with numbers of quit attempts. And we know that the number of quit attempts a person makes is associated with higher success. So even if it's just a lame try at trying to quit smoking, a half-hearted attempt, it counts. And we want to try and try and try again, and good insurance coverage encourages that, trying and trying and trying again. Yeah? We know that limited transportation is an issue. Jackie and John only have one car. They share this car. They're trying to get back and forth to work. They work opposite shifts because they can't afford to get childcare for Alicia. So it's another thing that's really causing them a lot of problem. And a lot of you do these in-home visits, right? Thank you for doing that, because I'm sure that makes all the difference for people like Jackie, that you're able to visit her and she doesn't have to try and visit you. How about this idea of cultural beliefs?
So there's certain cultural groups who aren't even going to trust us. You know, they're going to have a lot more trust in what friends have to say and what families have to say. Jackie may come back to me as a provider and say, you know, I don't know, my mom smoked when she was pregnant with me, and I'm fine. You know, I'm perfectly okay. And that message of you really need to quit smoking, that's what all the doctors tell you when they don't really know what's wrong with you. They just blame it on you by saying that it's the smoking. You know, and the whole thing is overblown and overhyped, and it's really not that big of a deal. And so even if you've got them kind of in the palm of your hand, they're going to go back to their friends and they're going to be like, you're really going to try and quit smoking? I don't know. I mean, that's not really such a big deal, is it? You could have just one. I mean, just one's not going to hurt. And I have heard people say that, right? That the stress of quitting cold turkey is going to hurt the baby more than a few cigarettes. And wow, is that doctor like 112 years old? I guess he'd dance himself all the way back to the American Medical Association for a review of his license. I mean, that's scary, right? And they have also this idea of this decreased faith in medications because there are a lot of sham treatments available to help people quit smoking, aren't there? Like if you're an insomniac and you watch late night infomercials, oh my gosh, there's the magnet that you put on your ear and the laser that you shoot at your temple. Then there's the aromatherapy stuff that you put in your nose, and all these bogus treatments, hypnosis and acupuncture that really, if you check the Cochrane reviews or you look at the U.S. Public Health Service guidelines, there's no actual evidence to suggest that those actually work to help the majority of people who try and quit to quit. But we know that there are treatments that actually work. But to this population, or to several of these populations, they view the whole bunch of it as equally useless, right? It's like the laser and the magnet and the nicotine patches are all equally bogus. And so that's what we're up against too, is they just don't have a lot of faith in the medications, which challenges our power of education. And there's sometimes a power imbalance in families here too. Like if you're working maybe with Hispanic families and a woman needs to quit smoking, she's possibly going to be less likely to assert herself, ask for good boundaries, don't smoke around me, ask for support, because of that power imbalance maybe between the genders in certain cultures. So there's a few things for us to think about here.
There is a real changing face, I think, in the face of poverty. Even if you looked at poverty maybe 20 or 30 years ago, if a poor person was poor 30 years ago, maybe they didn't have a washer and a dryer, but they were able to kind of pull together and get by. And maybe family members would help each other a little bit. But being poor now is different. Jackie has an iPad that she got as a gift. She's got a smartphone. She uses Verizon. Alicia has that unbreakable iPad and she plays Fruit Ninja on it. She's got things, but they're necessary things. If she wants to get wants to go to online college or whatever, she needs a laptop. Even poor people have laptops. Being poor right now doesn't mean you don't have things anymore. You're poor because you're on the brink of disaster. You're this close. You're like one broken down car to the whole thing falling apart. One missed paycheck to eviction. And that causes the stress that you were talking about earlier, right? This increased amount of stress that can really be isolating, because we're finding too that now, very differently than 20 years ago, the number of people who say, I have a close neighbor that I can confide in and talk to has gone way down. Our ability to talk to our neighbors over the fence. Jackie and John live in a huge apartment building, a huge subsidized rent apartment building. They don't know any of their neighbors at all. They all work weird shifts. They're doing shift work. They don't know who lives next door. Jackie doesn't have anybody that she could say, hey, could you come and watch Alicia for a minute while I go to the store? We had that 30, 40 years ago. You could ask your neighbor to watch your daughter while you went to the store, but people can't do that anymore. So they're poor emotionally, they're poor in support, they're poor in support family relationships. They're really torn apart by abuse and mental illness and stuff. So she's got a lot of challenges that we're facing, and being a low socioeconomic status kind of sets you up, because the tobacco industry markets their product as a stress management tool. If you need to relax, you need to have a cigarette. You need to have time to yourself and just chill out, you should have a cigarette. So she's very vulnerable to those messages. That's why we smoke, is because we're under stress. So this is, I want to have you consider that this is what Jackie tells you. I know I should quit. It isn't good for my daughter, Alicia. My husband smokes too. It's really hard to quit. I've tried a few times. But there's too much stress right now with the new baby coming soon. If I tried now, I know I couldn't do it. At least I'd cut down. Anyway, I heard that going cold turkey when you're pregnant can be a shock to the system and hurt the baby even more. Okay. I know, because I have been told, that you've all had awesome motivational interviewing training. So I'll offer you these potential multiple choice answers to this question. You can think about which one you think is the best. We could say, Jackie, I've heard that myth about quitting smoking when you're pregnant too. Can I share with you some important information about the risks of smoking while pregnant? Okay, not bad, right? You ask permission before educating. You're using EPE. You know EPE. This is good. So that you could maybe do that. Jackie, your family is really important to you, and you want to be the best mom you can be. Okay, it's a possibility. On the one hand, you're not feeling very confident you could do it. But on the other hand, you really love your daughter and your baby, and you worry about their health. Nice double-sided reflection. That's got a good ring to it. Good job cutting down. It sounds like you're doing the best you can. How many think A? Okay, excellent. You could get someplace with A. Seems consistent with the 5 A's that you're supposed to be using. How many think B? One person, okay. How many think C? Loving the motivational interviewing. Good double-sided reflection. How about D? All right, one person saying that's fine. Good job cutting down, because it has an affirmation. And I love affirmations. You're trying, good job. Let's take a look at then answer C, not saying the right thing, but maybe, well, it's hypothetically. A lot of you liked answer C. And I like it too because of the fact that it's a double-sided reflection. And she says, yeah, Alicia has had a few ear infections this year, and the doctor said it had to do with secondhand smoke. We at least try to smoke outside. You got change talk, right? She says it had to do with secondhand smoke. She acknowledges it's not good. That's importance, high importance. We like that. And that's something worthy of affirmation. We try to smoke outside. You can tell that's really great. I mean, you're going out of your way to keep smoke away from the baby. That's wonderful. Good for you. So that I'm not saying that's wrong, but I'm going to ask you to reconsider answer B. Only because of the fact that we're pointing out her values, and that's something that I want to talk about today. Is the importance of working with values and strengths when you're working with patients. This is a wellness coaching strategy that I'll have you consider. So her response potentially to answer B is, you're right. I really do want to be a good mom. My family growing up was kind of messed up, I raised myself because my mom worked all the time and I was pretty much alone. John and I are working ourselves to death so we can be there for Alicia, and her life is going to be different. And so I'm going to offer for your consideration that listening closely for your patient's values and handing your patient's values back to them when you hear them is an extremely powerful and moving experience for your patients. And while double-sided reflection is good, if you can get an affirmation of a person's values inside of a reflective listening statement, you've tripled the effectiveness of that reflective listening statement. So let me give you a little bit of an overview of that. I'll leave the discussion about it in a second because I'm interested to hear what you have to say about it and what you think. This is our wellness coaching model at Mayo, and it's got 5 E's. And if you're interested in this, you can come to my training. Because you could get more letters. CWC, Certified Wellness Coach, right? Which is cool. But here, what we've got is we've got engage, explore, envision, experiment, and evolve. And that's how we pull people through this experience of wellness coaching. And it can be through the whole experience of wellness coaching, like 12 weeks worth of coaching. But we can go through a lot of these in just a single session with a client as well. Engaging has to do with building the relationship. And I know you already do a good job with that. You want your patients to like you a little bit, think that you're a nice person, think that you care about them a little bit. So you're going to do things to build rapport and build trust. And how do you do that? How do you start out so that a person thinks you're okay? What kinds of things do you do? Just to
establish the rapport with them, get a relationship.
Establish rapport, get a relationship. You just kind of ask her what kinds of things she likes or what she's doing today. What are you going to do when I leave? You got important business to take care of today. How many kids do you have? You make small talk. You make nice. Explore, though, deepens that relationship a little bit. Exploring with your client has to do with trying to ascertain what their values are and what their strengths are and what they want for themselves. Because we've recognized that we may have a bit of a bias, that what we want on their behalf might be different from what they want from themselves. And this is a way to get this more connected. No matter what kind of therapy that you do with a patient, you may already be aware of this, but they've done this interesting and elegant studies, a couple of them, where you look at different kinds of therapy. You can look at cognitive behavioral therapy. You can look at solution-focused therapy. You can look at person-centered therapy. You can look at DBT. You can look at all these various types of therapeutic interventions that can be done. And then you can look at the characteristics that the therapist has themselves. And when you filter for the characteristics that the therapist has, the actual mode of therapy doesn't matter at all. They're all equally effective. And what's found to make a difference is clinical empathy, building a working alliance with the patient, having unconditional positive regard for the patient, showing genuineness, and having a collaborative nature. It's truly the relationship that you have with your client that motivates change more than any other kind of therapeutic intervention. And so I'm going to suggest that this is a way to improve that therapeutic relationship that you have with people. So in the explore stage, we're going to ask really powerful questions. And there is a researcher that I just love. Her name is Barbara Fredrickson, and she's done a lot of work with positive emotions. And she believes and shows in her research that positive questions cause positive emotions, and that positive emotions within your therapy session increase resiliency, increase your patient's openness to considering options, your patient's openness to listening to what you have to say if they're in a good mood. And so there's something called appreciative inquiry. So you could ask, rather than say, how was your day today? Ask, what was the best thing that happened to you today? And it completely changes the nature of some of our conversations. Because some of our patients, if you say, how are you today? They're going to be terrible. They're going to be just terrible, and everything's awful, and you wouldn't believe the stress I'm under, and let me tell you all about it. But if you ask what was the best thing that happened to you today, it does change the tenor of your conversation. So certain powerful questions can change the tone, and that power of the positive really generates these new thoughts and ideas. And we're going to look at this idea of looking at values and strengths and desires, because these three things come together like a scaffolding kind of, with vertical and horizontal pieces where you're going to build your patient's motivation for changing. You can cause a really rare thing to happen in your interactions, because you can make your interaction extremely unexpected. If you kind of put yourself in your patient's shoes, if you're being visited by a healthcare worker, there's something wrong with you. You know, not everybody has in-home visits from a healthcare worker who's going to try to intervene on your behalf and fix you. And so there's just that little bit of an implication that you needed my advice in order to get better. And so a patient's slogging in to me saying, yeah, my doctor sent me here to you, and he told me I really need to quit smoking, and here I am, I'm going to cooperate with my doctor, so what do you got to say? And there's not a lot of excitement there, right? But with the kinds of questions that we can ask, it's almost like you could be breathing rarefied air in that room, because whoever asks you about your values, whoever has a conversation about what is important to you and what do you care about. And so we can change the tenor of that conversation. So we are likely not going to share the same values as our patients or our clients either. And as much as we'd like people not to drink while they're pregnant and not to smoke while they're pregnant, our message is, you're not supposed to smoke because it's bad for your baby. But we don't care why they quit, really. We just want them to quit. So finding out what our patients' motivations are to quit may be more important than what our motivations are on their behalf as well. So I'd like to encourage you to be open to hearing about your patients' values and asking more about their values to find out what it would be that would motivate them more than our message to have a healthy baby, too. So expand your idea of what may be motivating. What else might motivate a person to quit smoking? Money. They're expensive. What else? Fear of?
Like if they have a family member or a friend who has cancer.
Okay, so I know someone who's got a tobacco-related illness, and I don't want that to be me.
Their appearance.
Their appearance, right? Yeah, smoking does impact a person's appearance, and maybe they recognize that in their loved ones, their mom having wrinkles or whatever. Yeah? Yeah.
Sometimes they're afraid that they might gain weight if they.
Weight gain is a big concern, and one of the biggest causes of relapse for women who quit smoking when they're pregnant and immediately relapse has something to do with the baby weight, too, has been shown to be motivating. Yeah.
An instant gratification type of a thing. So really, like, what am I going to get out of this right away? Not even like the long-term effects, but immediately, how is this going to be good for me? What is this going to do for me?
So we need an immediate, where we're not going to look at, you're not going to get cancer in 30 years, but what are the immediate benefits for people in quitting smoking? Yeah? Okay. Well, I have for you, thank you for that, a handout that says eliciting values in powerful interventions. And it has some techniques that you could potentially use with your clients, because it's not the only way to ask a person about their values is to ask them, what are your values? Whoever gets asked that, they're like, what's a value? Like, I don't even know what you're talking about when you ask me that, right? I wasn't even going to ask you that. I gave you a list. I mean, if I have said, with no list, give me your top 5 values, you would have struggled to come up with 5 values to even write. But with a list, that helps. There's a list of techniques that you could potentially use with patients that are really nice. And one of them is when you're building trust and rapport with patients, you're just ask them, tell me a little bit about your life. Who are the most important people in your life? What do you do for fun? Where do you work? Those kinds of things. You're listening carefully for a lot of things because you're multitasking, talented clinicians. You're listening for change talk, but you're also listening for values that you can hand back. And that's the most powerful way to get values from someone, is to hear them. So I'm going to ask you to choose one value out of the 5, right? I had to choose 5. And eventually here I'm going to ask you to choose one and partner with someone and explain to your partner what that value is and how it guides decisions that you make every day. Okay? And I'll give you an example. Like if you look at that Wordle, one of my slides has got a cool Wordle on it that has a bunch of values on it. And one of the ones on there is forgiveness. And I am high on that value. It's probably one of, if not maybe my top value, it's in my top 5. Everyone will get a second chance with me. I do not hold grudges. I am... you can totally pound on me, and I'll forgive you, to the extent that perhaps it's a fault. But I'm really high on that, and it manifests itself in a lot of places in my life, where I'm good at keeping friends, and I'm good at forgiving people. And I can give you a lot of stories, I guess, in my life of examples of where that's been true. And people really appreciate that about me. I think I have teenage sons, and my teenage sons have a few friends who've screwed up a lot, but they're always welcome at my house. And I'm always willing to give these kids a second chance. And so I'm high on forgiveness. And I'd like you to think of what your value is that you're really high on, and if there is a way that you can give an example of how that manifests in your life. But when you're working with your client and she's telling you about her life, be carefully listening for values you can point out. It sounds to me, Jackie, like you have a great sense of humor. It sounds to me, Jackie, like you really care about your family and you'd do anything to help them. She wouldn't maybe be able to come up with that value herself and tell you, one of my strongest values is that I care a lot about my family. But when you hear it and point it out and hand it back to her, it's a really extraordinary experience. Because people believe what they hear themselves say. And you give them that opportunity to hear what they're saying in a different way. And you can almost see your client sit up straighter in her chair, feel better about herself, and say and reiterate, when you say that, I guess you're right. I do care a lot about my family. Or thanks for noticing. Other people have told me I have a good sense of humor as well. But it's a way to create that positive emotion that I was talking about in your consultation that increases that openness to what you have to say. And there's some other techniques in here too. So a personal story. If you actually have a couple of minutes and you want to find out about someone's values, option 3 says, tell me about a time when things were going really well for you in your life. Doesn't have to do with health. Doesn't necessarily have to do with smoking. It doesn't have to do with any of that. But, was there a time in your life when things were going really well? And then be looking for opportunities for values that you can give back to her. And these are similar techniques that we can use when we're looking for strengths. And that's a whole different list of things, right? Strengths are different than values, but they both have a place in this. Okay? Questions about this? In what ways do you already do this with people? Where you're thinking, yeah, I do that with my clients. Does this have a ring to maybe something familiar, something that you're already having a sense for? You don't share it with just anyone. There's a little bit of vulnerability there. There's a little bit of trust required to share this. And so you know that if a person is willing to share with you some of these things, you've done a decent job of building some rapport and building some trust with your client if they're willing to share a little bit about themselves with you. And I'll have you consider, what do you think are some of these values, benefits of values in powerful conversations? Like, how could this make your interactions with clients just a little bit better if you paid a little bit more attention to their values?
They're more willing to work with you.
Maybe more willing to work with you. Like, you understand me. Build trust. So maybe, you're not just giving the party line, just another healthcare worker telling me I should quit smoking. Yeah. So when you say it taps into motivation, it really taps into motivation. If you understand even a little bit about what your client thinks is important, that gives you a huge angle of where to come from, what to leverage, what you can understand about someone in order to make a really powerful intervention to make a difference for this person. It gets to be really holistic too. Sometimes, and I know this is true for you in your work, that if you really make a good connection with a client, helping them have a smoke-free and alcohol pregnancy may be only just a small amount of what you've done for that person. And giving someone the gift of 20 minutes worth of discussion about, Jackie, what's important to you, could be a whole game changer for her, because it's something people don't talk about normally. And it's something that's lasting and has lasting value. Long after you leave her house, she's still thinking about this conversation and thinking about the things that she shared with you and pointing things out like, you have a strong religious faith. I see it when and I love the fact that you're able to go and visit people's homes, because, those of us who see people in our offices, all you've got is that person in front of you. If you actually go to people's homes, you've got pictures, and you've got kids' artwork on the fridge, and you've got golf clubs against the wall, and you've got all kinds of visual things that you can appreciate and comment on. And if they've got lots of maybe religious stuff around the house, maybe it's something you can. I see that it must be a really strong value of yours to have a really strong religious faith. How does that help you in your everyday life get through all the stress that you're under? That's something worth talking about for people. It really increases people's ability to be creative. So what we've got is a lot more than just goal setting. It's really building the relationship, because we know the relationship is what's going to end up making a difference. So this is what Jackie had to say to us a little bit ago. You're right, I really want to be a good mom. You know, my family was kind of messed up. I raised myself. I was pretty much alone. John and I are really working hard because Alicia's life is going to be different. So another multiple choice question, how can we carry that forward? It really sounds like you're trying to do the right thing, Jackie. I'm sure you care about the new baby just as much. Is that jumping ahead, maybe, a little bit? Is that risky? Maybe. You've had a really rough life. I can really empathize. My family was pretty messed up, too. You're like, oh, wait a minute, no, okay. You're better than I thought. You recognize it's not me. You've been through a lot, Jackie. You're a very strong and determined person. Where does that strength come from? Yeah, C, right? I love A. A's good. A's not wrong. But C is so much richer. It gets you so much good stuff. I mean, A might be a cool segue into your information that you'd like to share. But C is that you really care. You're not going to just try to get through your stuff that you want to get through with me. I know you got checklists and you got forms and you got that stuff and it's important, but you actually really care about me. You got these, and I'm sure you've finessed them over time, you've got these kind of suggested phrases, right, to use, but C really sounds like you've been listening. Yeah. Is listening so closely that you can point out these things, these strengths that you're hearing. Yeah, she says, yeah, I guess you get to be pretty strong when you have to take care of yourself. You just do what you have to do, you know? And that's a doorway for more affirmations. I really admire you are one determined person. You've been through a lot of stuff in your life. What kind of strengths do you have that have gotten you through all these difficult moments? And here you are, still standing. I really admire that about you. You know, and anything you can think of in her environment. I've got a wordle about strengths, right? All this stuff. You're a really curious person. You're a really kind person. You're really loyal to your friends. Any kind of story, she's like, I don't have a lot of time to talk to you because I promised that I was going to babysit Melissa's kids today. Wow, you'd babysit a friend's kids? Wow, nobody really does that anymore. I really admire that. You must be a really loyal friend. Any kind of strength that you can point out. You're wise, you're loving. You've got great judgment. I don't know. Maybe she's going to online school at night and you could really admire how hard she's working. But try and be sensitive to things because it can really improve confidence, right? When you point out you do have strengths. It's like, well, yeah, I guess I don't have nothing. I do have some things that I can work on here. And it creates more positive emotion. It's grounded. It provides a peak experience, too. It's also, you can use those strengths. So if a person comes around and says, yeah, I really think I do want to try and quit smoking. I've been thinking about it, and I think I want to give it a shot. How can you really leverage those strengths to help you? How can you leverage the fact that you have a great sense of humor to help you quit smoking? You can kind of laugh at situations and maybe not take yourself so seriously. And that's a huge, huge strength that not everybody has, that you can try to work into the treatment plan. It's, again, more than goal setting. It's building these relationships. And this can really help you do it. I want to just have you think of something in your head really quick. I want you to think about, because we don't always love our clients, right? Okay, they're not maybe all our favorite people. And so this might be really easy for the people that you like Like for Jackie, I think she's great. I would totally hang with Jackie. I would love to take her to coffee. She's cool. I don't always feel that way about my patients. Okay, so don't name names, but kind of think in your head of like your least favorite person. Like someone who just pushes your buttons and makes you nuts. Think of who that person is. Kind of bring them alive in your mind. And think of one strength that person has that you admire. Something, anything. You've got a lovely hair color. Sometimes you really gotta reach. But sometimes I have to reach with my clients too. I'm like, you gotta have strength, I swear to God. And I'm gonna find it. Kind of think of it that way. Think of one thing, right, that you can pull out to say, I appreciate you, about you, I admire about you, and it can allow you to see differently as well when you're listening carefully for these things. The last thing we're looking for is desires. And this is our client's opportunity to talk about the status quo. Desires is what's happening in my life now and what I want for myself in the future. And so it's okay to talk about challenges. It's okay to talk about stresses. It's okay to, say, if you were going to quit smoking, what kind of challenges do you think that you'd have? And okay, well, that would be opening up a Pandora's box. My husband smokes and my kids smoke and they all smoke at work. And you know what they're going to say. There's a lot of challenges. On the flip side of that, let's just say hypothetically, everything is exactly the way you want it to be. Everything is the way you wish it was. What would that look like 3 years from now? What do you want for yourself? What do you want for your kid? If a documentary film crew was following you around a couple of years from now, what would they see? What would you like your life to be like? And using those desires to create discrepancy, using motivational interviewing, is one way to get change talk. How is what you're doing now either consistent or not consistent with what you'd like for yourself? But sometimes when we have these discussions about desires, what is it that you want in your life? Where do you want to go? That can open up kind of a Pandora's box of losing control of the conversation. Do you ever feel like that happens? When you got your stuff that you need to talk about. So the clock is ticking, right? You've got how many people you have to see today? And you figure you've got an hour tops, maybe even less, that you can spend with Jackie. And then you get to Jackie, and what kinds of things is she talking about? How does this conversation get derailed? Car broke down. Yeah, that'll totally take all your attention, won't it? I'd love to talk to you, but I'm trying to figure out how I'm going to get to work. I have to be there at 5, and my car doesn't work. Right. Yeah.
They know that you're that person that will listen to them, so they kind of...
Yes. Sometimes they resent us kind of being the providers. Other times it's like, aha, you're the person I know who will show me that unconditional positive regard, who will be kind and who will listen to me. So it's an opportunity for me to tell you all these things that are going on in my life. That's hard when the conversation gets derailed. So sometimes our conversations we'll be working with a client and they'll be very negative about things, be kind of stuck, or be really tangential, be telling you all kinds of stories that are irrelevant to what you're trying to talk about. But we know that one kind of thing that people can do is particularly unhelpful for people, and that is excessive rumination. So ruminating is something that people can do when they're kind of depressed, when they're very stressed, when they have difficult life circumstances. You can spend a lot of time thinking about that and going round and round and round about that. And it's hard when we know we really need to redirect the conversation, right? In the patient's best interests, we know that we're really supposed to be helping them quit smoking, and you're like thinking, I got 20 minutes here. And do we really need to spend time talking about billing, right? And how do you get that back on track? What are some reasons why we're hesitant, I think, to redirect the conversation, to stop that person and redirect them back to what we want to be talking about? There's a lot of reasons why we as providers are hesitant to redirect the conversation. But there is a researcher, her name is Susan Nolan Hexema, and she did some research on the negatives of allowing someone to ruminate, right? So sometimes we think it feels like problem solving. So someone wants to talk about their boyfriend who is just like a jerk, and they didn't do this and they didn't do that and said that they were going to pick up the kid at daycare yesterday but didn't do it, and we're going to talk all about this boyfriend that's so annoying. And we want to be empathic, and we want to be kind, to be listening for values and strengths and doing this stuff. And so we allow this to happen. We're like, I'm sorry, boy, that boyfriend sounds like a pain. Oh, yeah, I'd feel that way if it happened to me, too. And allow that and allow that. We know that the emotion in the room can go lower and lower and lower. And we're seeking to have a positive emotion in the room because of all of the benefits that we know it can have. And so redirecting, I've given you on some slides here some suggestions for how to redirect a conversation to get it more positive again. There's a way, too, that we talk to women that's different than how we talk to men. So there was a study done. It was called the Michael and Michelle study. Have you heard of it? It's fascinating, I thought. Okay. So they interviewed, I don't know, like 100 people. I don't remember exactly how many. But equal numbers of people they interviewed and asked them about Michael and then asked the other group about Michelle. It was exactly the same story. In Michelle's case, her boyfriend dumped her. She loved this guy. She was devastated, didn't see it coming, was really sad. And they asked the participant, what advice would you give to Michelle? Okay. And then they asked the other group, the Michael guy, what would you do? His girlfriend dumped him. He was devastated. He was sad. How would he cope with that? And the advice across the board that everybody gave to Michael was, go to the gym, man. Just work it out. Hit the bike. Just go, like, get that punching bag and just, no, let's go for a bike ride. Distract yourself. That was another, they gave him, like, don't think about it. She wasn't worth it. Let's just go and, think about something else. Go do something physical. And the advice that they gave to Michelle across the board was, let's go talk about it. Let's get a cup of coffee, and we're going to, get to the bottom of this together, girlfriend. And what a disservice this is to Michelle, because it feels like we're going to fix it. It feels like we're working on fixing it when it just goes down and down and spiral and spiral and spiral, and how unhelpful that is. And so some things that you could do to try to get it back on track, because rumination gets in the way. One thing that you can do is gradually interrupt using a person's name. So when she's telling you the story, Jackie, I hear what you're saying, Jackie. Repeating her name seems to be grounding and acknowledging that you hear her, that you're not dismissing what you're saying. Use her name and validate her emotions. Never, ever skip this part. But you can say, Jackie, I totally hear what you're saying. What you're going through is terribly stressful. That situation with your boyfriend seems like it's really out of control. So validate, repeat, and summarize what you've already heard Jackie say. And not just once. If you have to do it a couple of times. And even summarize what she's told you so far. Let me try to understand what's going on with you, Jackie. So what I hear you saying is, you got a big vet bill, and this is happening, and this is happening. You got problems with this billing, and that's what's going on with you right now. And I really acknowledge that that's a problem. And then check for accuracy. That's what I'm hearing, right? Okay. And make a non-judgmental observation. We have about 20 minutes left to talk today. And I want to make sure that you get everything that you need from the time that I have to share with you today. And we can talk about your bill if that's what you really need to talk about, because I emphasize personal power and control. But I want to make sure that you get everything that you get out of this consultation with me today, and explain why why you're redirecting. You want someone to get the most out of the consultation that they can. Then connect back to values, desires, and goals. So when you validate her emotion, validate you feeling overwhelmed, you're feeling stressed out, you have a lot of things going on, I like to say, and I know there's so much more you could tell me about this. I know there's so much more that you could share with me if only we had the time. You want to really connect and let her know that you do care and that you do empathize by repeating these things, validating, and acknowledging. And I know you have even more stress that I don't even know about. And I care about you enough to want to make sure you're getting the most out of my time today, or the time that I have to share with you. And sometimes it can be a manifestation, right, of ambivalence. Like, I really don't want to talk. It's a deflecting technique on purpose. Like, I don't want to talk about the smoking issue, and so I'm going to get you to talk about just about everything else, so that we don't have to get back there. Or sometimes you'll see patients doing like a checking the watch thing, or they keep on checking their phone thing while they're talking to you. And it's okay to make a very non-judgmental observation about that. Jackie, I just want to notice that you keep checking your phone, and I want to make sure that there's nothing that's important that you need to check on right now, or if you need a chance to quick text someone or call someone before we go on, or if there's something important on your mind that we need to address before we go forward, because I just want to check on what's happening right now and acknowledge it in a non-judgmental way. But we can look again at the agenda, right? We've got about 15 minutes left here to talk, Jackie. And how would you like to spend that time? How can we best spend that time? By coming to an agreement on the agenda together, almost shaking on it, saying, or if you have this really important billing thing, like Sarah was saying, we got 15 minutes left. Is it okay if we spend 10 minutes talking about this thing? And before we leave, I promise I'll give you 5 minutes to look at your bill. Some kind of an agenda-setting agreement. The more you know this patient, if you see people for follow-ups and you see them multiple times, you get a sense for their personality and their values, and there's some other kinds of techniques that you can use, like you can maybe even use humor. Like if you've redirected people away from their repetitive stories before, sometimes it's okay to be like, okay, Jackie, here we go again, talking about the boyfriend, and I want to be able to bring you back, and maybe she'll be able to, have enough rapport with you to recognize it and laugh and say, okay, yeah, you're right, I did it again. But your thoughts about these using some of these techniques to maybe redirect your conversations? You think there are maybe a couple of things you could try? None of them are like perfect solutions. But we call this in wellness coaching empathic redirection, because we know that not redirecting people who are off track is kind of unethical, because of what we know about allowing people to wallow in negative emotions and allowing people to waste their own time. We're really not doing them a favor, and it's really actually a very compassionate thing to do to help people get back on track with the conversation. You have to really work at this sometimes, right? Positives. But one of the activities that I do when I do these trainings, if we had like, we could come back to this afternoon and I could have you do more things, is I could have you do this affirmations exercise where I put you in pairs, and one of you is supposed to be just like yapping endlessly about like your trip to Walmart yesterday. And the other of you is only allowed to respond with affirmations. Nothing else. No questions, nothing. Only
good observations that you can make. Affirmations, and see how long you can keep doing it without saying anything else except affirmations. And it's an amazingly instructive. Try it next time with one of your clients, just to be like, look at your watch and see how long you can just offer affirmations and nothing else. It's really interesting, and but it may be easier than you think, and have a really good outcome. Well, I saw your 2 minutes. So I'm happy to relinquish the floor. Thank you guys for doing that. It was really good.